think one of the coolest things, and maybe one of the oldest things that we've carried over from older medicine, is shocking the heart back into a regular rhythm. I think classically, anyone who's watched a TV show about medicine has seen a doctor or medical providers grab the paddles and basically shock a patient back to life. Not only do we use electrical conduction or the Zoll or AED to shock somebody back to life, but we can also use it to shock somebody from an abnormal rhythm back into a normal rhythm before they're dead. The way it works is we have two pads that we apply to the patient. Usually it goes on the front of the chest, and then one it goes on the back, and that's what will conduct the electricity. Some diagrams will also show that you will put one pad on the front of the patient and then another pad on the left side of the patient under the armpit. Ideally, you just want these pads to be on either side of the heart so that as electricity is conducting, it goes through the heart. Most commonly in the ICU, the reason I'm shocking patients is because after cardiac surgery, patients have a high risk of developing what we call atrial fibrillation or atrial tachycardias, and that's where the atrium of the heart is not conducting as normal, and so patients can have very high heart rates and end up with low blood pressure because of that. There are other ways to treat these abnormal rhythms, like the medications. However, when patients' blood pressures start to drop, that's when we consider this a medical emergency, and we resort to shocking the patient to restore normal sinus rhythm as quickly as possible. In terms of the energy that we use to shock patients, usually textbooks will say you shock someone with 120 to 200 joules of electricity. I tend to start my shocks with 200 joules, which gives me a pretty good success rate with the first shock, because if you aren't successful with the first shock, then you will increase your joules for the second shock and subsequent shocks. And I don't typically shock anyone more than 3 times. Usually that means that the defibrillation is not going to work in that scenario, and you might want to work on more medical management for that patient. One key distinction when doing defibrillation for patients with atrial tachycardia is like atrial fibrillation versus when patients are getting CPR for something like ventricular fibrillation and ventricular tachycardia is if we're going to do synchronized versus unsynchronized. For atrial fibrillation, we do what's called synchronized cardioversions. And so the Zoll machine or the AED will basically start to recognize every time a QRS complex comes up, which is when the ventricles are going under depolarization. Now, when we shock the patient, we basically cause depolarization of all the myocardial cells, meaning that they all fire at the same time, and then they all relax for a period of time at the same time. This refractory period is really where the heart resets, and during that pause, the pacemaking cells at the sinoatrial conduction portion of the heart are able to restart and hopefully get back into a normal sinus rhythm. Now, this pause can last a prolonged period of time to the point where you might need to use medications like atropine or glycopyrrolate to get the heart rate back up. And so I always keep those emergency medicines with me whenever I do cardioversions. The reason we synchronize the shock is so that we don't deliver the shock on a T wave, which is the repolarization phase of the ventricles. If you were to shock the patient during the T wave or during the repolarization, that's what we call the vulnerable portion of the cardiac cycle. During this vulnerable period, if you start depolarizing other myocardial cells, you basically have repolarization of cells at various times, and that heterogeneity or that difference of repolarization, depolarization of myocardial cells will basically flip a patient into ventricular tachycardias or ventricular fibrillation, which then would end up in a situation where you then have a coding patient. This phenomenon is called an R on T phenomenon, and it's something that we avoid basically by doing synchronized cardioversions. Last thing to note is that these shocks obviously will hurt, and so patients who are not already under sedation or on a ventilator will require some sedation to get this job done. What I typically do for these patients is give them a minor dose of propofol to the point where they fall asleep, give them some extra oxygen so they keep their oxygen saturations up during this time. And then once they're unresponsive to me and they aren't talking to me anymore, that's when I deliver the shock. And pretty much nobody will remember the shock when they're knocked out with propofol. They'll still be breathing on their own, and they'll come back to usually within about 2 to 5 minutes. Sinus rhythm is extremely important for a lot of our cardiac ICU patients, especially patients who have hypertrophied or really thick myocardium or thick hearts. The atrial kick is really important to increase their cardiac output, and so restoring normal sinus rhythm is really important for us getting them out of the ICU.